All right, hi everyone. Welcome to Wednesdays. All right, I'm here with Dr. Gill Suarez. He's a very good friend of mine for 20 years. So let me get everybody else on. Hold on. So they're starting to come on. And we're in his office today, you guys. This is going to be phenomenal. So everybody stay tuned. Don't go away. So let me get Terry on. So then I go over here and I invite Terry. Terry, invite. Okay, Mel. Boom, invite. And hopefully they will come on. Hi, everyone. Happy Wednesday. There she is. This is Terry.
Terry.
This is Gill. Dr.
Nice to meet you, Terry.
Yay. We're getting set up.
You're a dentist, right?
Yes. I practice. I've been a dentist since 93. I practiced in Vegas for 25 years, and I made the switch to just treating patients with obstructive sleep apnea about 7 years ago. So
awesome.
This is all I do.
I can't wait to hear it because, you know, I do a lot of diagnosing of sleep apnea. I've done a lot of courses, but I do not treat it. So I'm really glad you're doing that because this is something that people need to be aware of.
No, absolutely. And you're in the Houston area, right?
Yeah, I practice in Houston. Yep.
Right.
I became friends with Peg not that long ago. We're like
in that dating show.
Yes.
We met in the dating show.
And I'll just, you know, I don't call her Peg. When I met her, it's been Peggy, and it's always Peggy, and it's hard to. I know you guys call her Peg, and calls her Peg. But.
No, I started off with Peggy, and
Yes.
then I had to quit and call her Peg because I called her Peggy most of the time on our dating show.
Right.
And then I realized that people called her Peg, so now I call her Peg.
Yeah. So we've been friends for 20 years. Our kids went to the same school together, and when he was married, I knew him and his wife.
Wow.
And we've been friends ever since.
Yeah. We were just figuring it out. It's 21 years.
21 years. We used to board together all the time.
Yeah.
We would go boarding together.
My patient.
That's
why
cool.
she was my dental patient.
Yep, I was right. So we have a lot of, you know, history together. It's been fun. And watching the kids grow up. I mean, our kids Sophie was 3.
Yeah.
Right?
And Nico wasn't even in Maryhill then.
Yeah, and Nico was just a baby.
Let me get this situated. You've got a fan here. They said you are the best doctor in Vegas for sleep apnea.
Oh, well, thank you.
David Moore, in honor of you, my logo shirt.
Got it. I got my sleep solution.
I'm going to back this up so we can actually. There we go. We're both in black scrubs.
Yes,
there we go. Is Bill coming on?
I don't know. I called him right before and he was at the store. I don't know. Hold on.
So we should probably get started then.
Yeah, let me invite him one more time. Hold on. I know. And if not, that's okay. We'll just roll, baby. We'll just roll. Okay, everyone. So this is Gill Suarez. Specializes in sleep apnea. He just opened up this beautiful office here in Las Vegas. It's absolutely gorgeous. And he is going to talk about sleep apnea and the different machines, the different, appliances. Thank you. The appliances that you have. So it's going to be really good. So everybody definitely stay tuned. All right.
So let's dive in. Let's talk about what is sleep apnea.
Well, let's just start. Sleep apnea, by definition, apnea is without breath. So it's when you go without breath while you're asleep. It's your airway can narrow, your airway can collapse. And there's different ways that it could be a lot worse on patients. It affects so many different, so many different aspects of life, like as far as, there's direct connections to heart disease, diabetes, weight gain, motor vehicle accidents, depression, Parkinson's. So it affects a lot. It's basically your O2 levels, your oxygen levels are going to drop at night due to the airway narrowing or the airway collapsing totally.
Wow.
So, go ahead.
Hold on just a second, you guys. Sorry, I have to take a pause just for a moment. Mel's trying to get in. Hold on.
Let him in.
I'm keep inviting him. Sorry, guys. Okay, so go ahead.
So why would somebody come to a dentist versus because I know we are the first line of defense in diagnosing sleep apnea. So what would it be that you'd look for in a patient that has sleep apnea?
No, good question. So number one, and I always say, not just the dentist, honestly, the hygienists are really first line because, the hygienists, normal dentistry, where their hygienists are seeing the patients 2 or 3 times a year. They spend a lot of time with them and they get to know them well, their families, how Kelly was at our office.
Right.
But the main thing you can look is, ask them, do they snore? Are you tired during the day? You can look for neck size for men 17 and above, neck size for women 16 and above. Look for the tongue. Is there scalloping on the lateral borders of the tongue? Do they have tonsils? Have them say, look beyond the teeth. We always tell the dentist, when I lecture to dentists and hygienists, look beyond the teeth. Have them say, Okay, do they have huge tonsils? How much of your airway can you see? Are they, and the other thing too, Terry, would be grinding teeth. You see somebody with the worn, they brux their teeth down like crazy. Underlying obstructive sleep apnea, a patient needs to open their airway. Your brain is not going to let you die. You will open your airway. So you're going to grind teeth, lengthen your neck, so when you've sat, like, let's talk about cosmetic dentistry. I know you do cosmetic dentistry. Have you ever had those cases, you do beautiful 8 upper veneers and the patient comes in and they broke one like a week later? How frustrating is that? As dentists, that's like that. Your stomach just drops. Think about it. There could be an underlying cause of obstructive sleep apnea, and they're going to be grinding and chipping crowns and teeth. So you can look, those are the main things: big tongue, big tonsils, large neck, worn down teeth. Those are really the most common, things that we're going to see.
So my son had double jaw surgery. He's only 36 years old. And the reason he had it is he was diagnosed with sleep apnea. And what about the position of your jaw? People that have a recessed jawline or chin have a tendency to have sleep apnea, correct?
Correct. They have smaller airways. So one of the things you do, if you look at somebody's profile, and you see, retrognathing, we're going to know what that is, the jaw that's pushed back, they're going to have a higher, predilection to having obstructive sleep apnea. That's common. You're going to see a higher rate of sleep apnea in those patients. Now, usually with kids, I'm glad you brought it from the kids, the main treatment with kids is going to be, number 1, orthodontics. Get them evaluated by an orthodontist. 2, an ENT. If you see really big tonsils, the adenoids in the tonsils could be blocking the airway, and cause some of this breathing disorders for the children at night. So definitely get them. Those are the 2 main things that you do for kids. So maxillary expansion, a lot of times they have to have their tonsils out, and that's really it, because kids should not be snoring. And another thing that kind of leads into this is that a lot of kids are going to be misdiagnosed with ADHD, hyperactivity, things that they could be a sleep-related breathing disorder at night, and it's not that. And these kids, now imagine a kid that's just tired because he's not sleeping properly. Now you're going to put the kid on Ritalin, put him on speed. How much worse is that situation? So really, it's the dentist, the orthodontist, and the ENT for kids.
So what's the correlation, or how many people that snore actually have sleep apnea?
Ooh, it's one of the main factors that you ask patients. So it's probably around 70% of patients that snore, they're gonna have sleep apnea. But the only way you can be diagnosed is through a sleep test. And there's 2 types. There's an in-lab sleep test and there's a home sleep test. The majority that we see now is mostly home sleep tests with physicians. And we are going to have our newest patient here. We're going to get her all set up with a sleep test. And while we're talking about that, this is a sample, but this is what Peggy is going to be getting. This is called a WatchPAT. And what this is the computer. So it goes on your wrist, you have 1 finger probe and 1 lead that goes to the top of your chest. You sleep with this at night. You'll download the WatchPAT 1 app. All this data gets uploaded through your phone, sent to the sleep specialist. He has all the raw data, and he will interpret all the raw data and come up, and then they call Peggy back with the diagnosis if she has it or not. So it's as simple as this. A lot of patients don't even want to get tested. Some new patients will come in and, like, Dr. Suarez, if I have to go spend the night in one of those places, I'm not going to do it.
Right, exactly.
And, it's hard to sleep in a sleep lab. Foreign environment, you got 20 leads hooked up to you. You got a camera on you all night long. They're going to probably, and the room's cold, they're probably going to wake you up in the middle of the night. And then they're going to say, hey, Peggy, have a good night's sleep. So home sleep testing is probably about 80% of the testing that we see nowadays.
I will tell you, when my son had his jaw surgery and the sleep apnea was corrected, he dreamed for the first time.
Yeah, he hit REM sleep. That's when we dream. So we absolutely. But what your son had was, it's not that common. I'll be honest with you. When you have, mandibular advancement surgery, it's pretty aggressive. But for the right patient, absolutely, that should be a
No,
consideration.
I wouldn't recommend it for my worst enemy. He probably should have had ortho done the right way when he was younger, and it would have prevented it to expand his palate. But I'm really glad that you're doing this, because more dentists, people don't realize they don't have to be on the CPAP machines. They can have oral appliances, and that's the
Yeah.
beauty of this.
Yeah, study has shown only about 40% of patients will comply and wear the CPAP. I'm
They
a
hate
CPAP.
it.
Yeah, for the right patient, honestly, Terry, it is a life changer, a life extender. When you have somebody who has very severe sleep apnea, having 30 and more events per hour is severe. So if somebody has 100 events per hour, they're desaturating into the 70s or 60s. That's a life-changing piece of equipment. For that patient, they should be on it. So that's why you test first, and contingent upon the results of the sleep testing, that's the type of therapy they would need. But if they fail CPAP, which 60% do, then oral appliance therapy done the right way should be next. And then there are other options. I know Dr. Smith, I was watching it last week. He mentioned a little bit about Inspire. That's another option for patients, but that's surgical. That's a surgically implanted device that's called a hypoglossal nerve stimulator. So basically what it does, that's the little battery pack is here. They have to make another incision. ENT surgeon does this, make another incision underneath your jawline. And there's a lead that goes to the hypoglossal nerve. So basically what it does is, once everything's healed after a month, you turn on the device. It's like a little remote control. And then basically it knows when you stop breathing, and it shocks that nerve, and that tongue, it shoots the tongue forward. It keeps the tongue out of the airway.
How
That's what,
often do you have to replace the battery?
I don't do that procedure, but
Yeah.
I believe it's at least 5 years till they go in, and then
Oh,
that would just
okay.
be a small little incision surgery here. But I do work very closely with an ENT she's also board certified in sleep here in Vegas. So there are certain ENTs that do this kind of procedure, and on top of that, do the tonsillectomies. Can do different procedures like that too. Or UPPP is another one that's done for sleep apnea.
So you
That's aggressive.
basically save people's lives, because sleep apnea is a silent killer.
Oh, it definitely is. Undiagnosed sleep apnea, absolutely. That's the big thing. The main message I can get out is for patients is get tested. It's easy. You don't have to sleep in a sleep lab. There's all kinds of different home sleep tests. This is a WatchPAT. I'm a big believer in this one because it gives me positional data, which is another key component that people don't realize is what body position do you sleep in.
Mhm.
If you're on your back, it is way worse, the apnea. It's called positional apnea. Compared to side sleeping is the best. So
I
that's
sleep on
what,
my side.
well, there you go. So it's always
Yeah.
better. But if you ever have been around somebody, a significant other, kid, anybody, as soon as they roll on their back, if they have a couple drinks and go on their back, the snoring's terrible and the sleep apnea is the worst for sure.
Wow.
So,
Okay. You want to talk about the appliance?
yeah. So basically, patients, what we do is oral appliance therapy. So if you can't wear a CPAP, you're going to be referred in. The majority of, I'd say 95% of my business is all physician referrals. So that could be ENTs. I even have some plastic surgeons that refer in, cardiologists, pulmonologists, concierge doctors, primary care, neurologists. So what we do is oral appliance therapy. And there are different companies that make the oral appliance. Now, right now, oh, and there's Mel.
There's Mel.
What's
Hi,
up,
Mel.
Mel? Nice to finally meet. So
Likewise.
what? Hey, excuse me.
Likewise.
Oh yeah, yeah. Nice to meet you, Mel. So there's a few different companies that we use. My favorite, I've been using this a lot, and I personally been using this one. It's called AirVata. And it's a 3D printed nylon. So we do, Terry, you'll get this. We do a digital scan of the upper teeth, a digital scan of the lower teeth, and I call it my therapeutic bite position. That's the equipment I use behind me. It allows me to figure out what's the best mandibular position on a vertical and on a horizontal axis. That data gets sent to a specialty lab, let's say like AirVata. They design the cases on computers, and these get 3D printed. So, and they're very soft, you know, very soft, easy to put in.
And they usually fit on the upper?
The upper and lower. These are called mandibular advancement devices. So MAD. So they keep your mandible in a forward position and they do not let your mandible retrude back. But from whatever that therapeutic start position is, they all have the ability, it's a standard of care. They have the ability to bring your jaw forward a little bit at a time, and they'll have different mechanisms for that. For example, another company that I've used is ProSomnus. Great company. Everything's precision milled by robotics. They call it a puck that they start with. And these are precision milled exactly to your teeth. So this is one that called the ERPS. That gives you can open really big. You got a lot of lateral movement. But the main thing, it doesn't let the jaw move back, and you can always move the jaw forward little bit by little bit. So there are different style appliances. I do have one surprise now that Mel's here. The owners of AirVata that I've gotten to be very close with, they're going to make each of you, including Peggy, an oral appliance. So all we need is a digital scan. Mel, we can help you get set up with that. If you come to Vegas, I'll do it for you. Your dentist can do it and send it into AirVata, but we're going to get you guys all set up with your own.
What exactly that is that going to do
if you're
for sleeping?
All right. Well, let me see. I don't know if you snore or not, because usually you come in for the consult, we talk about this. Does he snore?
It's not.
Okay. Well, good. You're that exception there, Bill. But most patients, I can tell you, they'll come in, and one of the main things I hear is snoring. I call it like the sleep divorce. You got husband and wife sleep in different bedrooms because of the snoring. So one of the main things that your patients will see right away is the snoring decreases. But the main thing it's doing, it's keeping the jaw forward. The tongue will be forward too. It doesn't let your mandible retrude back, and it keeps that airway open. So you're not getting those collapse over and over. Your airway's not collapsing at night. Or if you're on your back, the jaw retrudes, the tongue goes back with it, and you obstruct your airway that way too. So it keeps your mandible in a slightly forward and open position.
Is there any type of adjustment that's needed after you deliver the oral appliance?
Sometimes. Now, the better the lab, like for example, AirVata, that's precision, it's 3D printed, I should say. We have these special little tools that almost look like little fingernail clippers, and you can trim a little bit inside. But with the printed nylon, very minimal, they're very comfortable. With the other companies that do precision milling, they can tend to be a little tight, but you get a little round burr. Terry will know what I'm talking about. You can ever so slightly go on the interproximals and adjust, but it's minimal if you use a high quality lab. These are all, specialty companies. These aren't dental labs that are making these.
Wow.
And also, say someone has cosmetic dentistry, they have veneers or what have you. Does this affect your bite when you wear this? Because I know I was going to start to do oral appliances, and I was afraid it would change my patient's bite. So how does that work?
Great question. Now, that could be from the type of appliance, number one. So if you have appliances, the old school ones that have ball class, or the ones that have these really soft liners, and teeth can move. Even with Invisalign therapy, we have patients that clench at night, you can intrude teeth. But if you're doing a high quality appliance that's 3D printed or precision milled, and the other key factors are something called a morning repositioner. So it looks like it could be made out of like putty, or it could be precision milled too, and basically gets the patient back in their normal intercuspation, their normal bite. So in the morning, you wait for you feel like your teeth are touching. I have to make sure everybody can touch their teeth in the morning. You can use that little splint to get you back into the morning reposition, get back in your normal bite. But we don't really see bite changes. It's very rare when you use a high quality company.
Okay, and the last question I have that some people, I know, but if you wear a night guard at night, you obviously don't need to wear your night guard, or you can't wear your night guard if you're wearing a CPAP machine, correct?
Correct.
With oral appliances, that's going to take the place. But if you have a CPAP machine, you wear a night guard if you're grinding. No, because it keeps your mouth open, correct?
Yeah. Now, but the biggest thing with that, the biggest negative of night guard, especially a monoplane, like a flat one that's nice and shiny so patient can grind all around, that's going to allow your mandible to retrude back at night. So that could make those types of appliances, those night guards, can make your sleep apnea worse.
So what type of night guard would you recommend? Let's say a patient doesn't have an oral appliance. What type of night guard do you recommend then?
Well, honestly, what I would do, the newer ones, this company, AirVata, they have you can just wear an upper guard that helps keep your jaw forward. But it's a tough situation. If you think that the patient could have obstructive sleep apnea, I would get them home tested like we're going to do for Peggy. get them tested, because there could be an underlying obstructive sleep apnea issue. That's what they're causing, that nighttime bruxing and breaking some of the veneers or chipping them. But what I have patients do is they're going to not wear their night guard. They're going to switch to the oral appliance. And for somebody that's done a lot of cosmetic work, I would get something like a 3D printed nylon that has some flex to it. Or one of the other companies makes another material that's precision milled, but it has a little bit of it. It's called an EVO. It's a little bit of a soft internal. But
I feel like I'm getting a continuing education dental course here. This is awesome for me.
I'll sign your CD for you.
I have a question.
All right.
Can stress bring on sleep apnea?
Stress, good question. Stress will temporarily cause you to brux or grind or clench.
Okay.
Not necessarily is going to bring on sleep apnea.
Okay.
But you could have some of the, symptoms if you've been grinding, but that's that chronic grinding that's really bad. So stress, I would say just some acute stress, no.
Because when I was working, when I was on duty for 20 something years, I would wake up in the middle of the night and I would gasp for air.
Well, you probably have. We're going to find out, but you probably had.
And then
it was undiagnosed.
And grind. I would just, the little Invisalign retainer things. I would just literally chew right through those.
Yeah, so that means you're bruxing, you're under high stress, your type of job that you had, and you're like I said, your brain is never going to let you choke to death. You will open your airway. And one of the ways you do is you'll grind your teeth forward, side to side, lengthen your neck, cough, switch body position, but your brain's...
That's why you grind, is just because your body's trying to compensate and trying to get air in.
You're trying to open that airway. And if somebody's a chronic grinder, like Terry will know, you see somebody with these really flattened out teeth, you can see the wear pattern on them. You can just see they're flat in their upper front teeth and lower front teeth. That's, it's most dentists, we're not trained on this. We don't know. Okay. It isn't until you do all this extra training and specialize in this.
Can you touch just real quickly on the connection between sleep apnea and anxiety and depression?
Yeah, well, there's, because we do get referrals from psychiatrists. So one is just going to be the apnea is going to decrease your oxygen little bit by little bit. But when your airway collapses, you go into a fight or flight response. Your cortisol is going to go up. So your brain goes, oh crap, we don't have enough oxygen. So your heart rate goes up, your blood pressure goes up, and you release cortisol. It's a fight or flight response. So these people that are on a high sympathetic drive all the time, yes, it's going to be that's the correlation to, to patients that are going to be treated for depression and other things like that. And just poor sleep, they're going to be irritable. They're not getting proper REM. They're not getting enough deep sleep. They're getting a lot of light, fragmented sleep.
Interesting.
You guys are kind of fuzzy.
Are we?
Mm-hmm.
All right.
Is it the light or is it?
No, it's probably.
No, it's not clear.
It's not clear?
No. It started out clear, but it's not super clear.
You know what I've noticed when we add, when there's 4 of us on here, I noticed that. I've noticed that a lot. So just maybe the overload of the
Mel,
do
you have ear pods in your ears?
I do not.
Okay. That's not it.
All right. Well, one of the other, well, I can go over a bunch of stuff here with you guys, but one of the things that I think that I tell patients is there's a way that you can start kind of testing yourself without having to go in. Number one is, because snoring is an indicator, there is an app on your phone. You can download an app called Snore Lab, L-A-B. And Snore Lab basically records you, and you can hear yourself in the morning, and it'll play it back for you, but you can also get a number. So if somebody monitors their snoring, and this is my favorite little tool that I recommend to patients. It's the WellU, W-E-L-L-U-E, WellU O2 ring. This is basically an overnight pulse oximeter. So if somebody can monitor their pulse oximetry all night long and they're snoring, when you take this ring off, all the data all night long, it'll Bluetooth to your phone. So you're going to see, because it's all about oxygen, you're going to see what percentage of the night were you, just like a sleep test, between 95 and 100, percent oxygen, between 94 and 90, and below 90, all the bad stuff we don't want. So those are 2 easy ways, pulse oximetry ring. I know nowadays people have Oura rings and other things. Those can work. This is just straight up pulse ox, and I think this works the best. But Oura rings in combination, or any of the other rings, there's Reebok has one that you can wear in combination with the Snore Lab app. You can see if you're desaturating below 90 at night, you're probably very probable you're going to have a sleep-related breathing to sleep.
Monitors your OSATs.
That's all night long. When you take it off, it'll Bluetooth your phone. It has a beautiful graph.
Wow.
It looks just like a part of a sleep test.
Oh, wow. That's
What's
cool.
the app called again?
The Snore Lab is the app to record
Okay.
you. This one that's called the Wellu Ring, and that comes with its own app that's free when you buy the ring. And this is all Amazon. Anything I recommend to patients, they can get it on Amazon.
And we'll put this all in the comments
Yeah.
for everybody after
That's
the
great
live.
information to know. I'm going to pass that on to my patients.
Yes. So the
Sure.
Wellu
Yes.
O2 ring works great with the Snore Lab app. Now I have other little, you can call them hacks. I have just call my recommendations for patients depending on, like we touched on body position. Sleeping on your back's the worst. What is my go-to? Soft cervical neck collar, 2.5 inches. Get this on Amazon for like $9. And that prevents you when you're sleeping on your back, already got gravity pushed on your neck and on your chest. The jaw retrudes back, you collapse your airway down. So that'll keep you from collapsing down, and you combine that with the oral appliance that keeps your mandible from retruding back. So, different things like that patients can do. There's things for the nose. So if you look at a patient, they got narrow nostrils or they collapse in, their alas, nasal dilators. There's a new one, Intake, that's pretty cool. It's like a magnet. It's been all over social media. It actually works really good.
What is your opinion of people that suggest taping your mouth so you just breathe through your nose at night?
Good question, because that's going to lead into what we're going to do for Peggy. Now, the only way that I recommend mouth taping, it's very effective, and I'll explain why. But the main thing is, with my equipment that I use to work up patients, this is very specialized equipment just for sleep apnea workups that I do. We use a piece of equipment called a rhinometer. I know that Dr. Smith will appreciate this one. So basically, it sends sound waves up the nose, zero pain, and we're looking for 3 areas of the nose: the nasal valve and the turbinates. We're going to want to make sure that there's no constrictions. If the rhinometry test is perfectly fine, then I feel comfortable recommending mouth tape to patients. But what it does, the main thing that it does is increases nitric oxide production through nasal breathing. But I tell everybody the best side effect is snoring goes way down. And a lot of my older patients that have issues with dry mouth is better. But you need to make sure their nose is okay. So, I'm lucky enough to have this piece of equipment, but I know some dentists that do what I do that'll look up there with a scope, just like an ENT does.
Doctor, have you seen the pillow that allows you to sleep like upright? It was on Shark Tank. It came to my feed. I gave it to Dr. Smith. So I don't know what it's called, but it was like you can sleep upright in your bed.
For a lot of patients, a little bit, nowadays, so many people have those special beds, but I'm not familiar with that particular pillow. The 2 that I recommend are basically, I call them positional aids. So like I said, sleeping on your back's the worst. So there's one pillow called an open air pillow that looks like a big number 7. You can just Google it, open air pillow, and it keeps you on your side. So basically the top part of the number 7 you sleep on, the long part of the number 7 is like on your back, so you can't roll back. So it keeps you on your side, or you can flip it the other way. Also, for all the moms out there, pregnancy pillows. They're meant to keep the moms on their side. Pregnancy pillows is another exceptional positional aid, about $50-$60 on Amazon. So that's always, I have a whole list here of recommendations, and I can give them to Peggy. We can put them up. But one of the things is positional aids, especially when we get a sleep test back, and I'd be like, wow, Mel, when you're on your back, your apnea is, it's moderate or severe, but when you're on your side, it's very mild. Just by keeping you on your side, we can improve your sleep apnea.
Well, some people have issues with, their shoulder, their neck, where their head is not in alignment because they have a different pillow. So sometimes you can't sleep on your side for more than 20 minutes. You're tossing and turning. What do you think about that?
Yeah, so patients have back issues. That's when I go to wherever it is, the soft cervical neck collar. This is my go-to for my back sleepers. And I can tell you I've had 2 physicians here in town that are good friends. One's a plastic surgeon, one's does a lot of like hormone therapy. And just this alone, their snoring went way down. You combine this with oral appliance therapy, because the plastic surgeon in particular, he was doing the pulse oximetry ring. And he texts me in the morning, Gill, look at these numbers. I was like, well, what did you do? And he goes, he's the one that gave me this idea about 4 years ago. He goes, I had the that, cervical neck collars that I recommend to patients after certain surgeries. And he goes, I wore that because he had to sleep on his back because of a rotator cuff issue. Mel, so because he was back sleeping, his apnea was worse. All of a sudden, his O2 sats are increased just by the neck collar and the appliance.
That's interesting.
So that's what I do. If you have to sleep on your back, use the soft cervical neck collar. But
So
try other pillows.
what would you say the biggest myth is about sleep apnea?
Well, first of all, that only fat men have it. That's really it. Only men, big truck driver. Is a morbidly obese man going to probably have sleep apnea? You can pretty much guarantee it. But I also have, this is one thing that was like a shocker because I switched to this type of treating patients with sleep apnea about 7 years ago. Petite Asian little grandmas are going to come in and they have just as bad as sleep apnea as some of my big NFL players, some of my big bodybuilders. Or actually would be a lot worse. I've had ex-NFL players have very minimal sleep apnea and some like Mr. USA comes in very mild sleep apnea. And then I got this little Asian grandma that weighs 90 pounds that has severe sleep apnea.
Why is that?
The size of their airways, they have nasal issues a lot of times, size of their airways, and they're just genetically smaller. And as we get older, things get not as rigid, a little bit more flaccid, and their airways more collapsible.
Doctor, do you send your patients out for a nasal scan?
Well, if I when I do the rhinometer, if there's any constrictions or any issues at all, I do refer to one specific ENT group here in Vegas, and there's one doctor in particular. She's the only board certified. She's an ENT surgeon and board certified in sleep apnea. She's very unique. So I do send out to, her name's Nicole Mole, and I send out to her all the time. But my screening is this. And if I see any collapse like that, I can just visually see. But when I do the rhinometer,
wouldn't you get a nasal scan anyway? Just like you rule out like for an X-ray or something. Just you do it normally.
Yeah, a lot of dentists are going to have in their office, right? If they're going to have CTs, cone beams in their office, and you can look at the airway and you can look at the nose there. Absolutely, if the dentist is trained in that, that's one way. But the final diagnosis, if there's anything, I always revert to my ENTs, for that. But you're right. And you can see the size of turbinates, you can see the size of certain hard structures in the nose with the cone beams. If they have enough, a lot of them have to have a big enough field of view. Some of them are just more narrow, but certain of them will for sure.
If you have somebody, I know that sleep apnea is not really associated with weight, but let's say somebody is obese, has sleep apnea. If they lost a lot of weight, is there a chance that sleep apnea could improve or disappear?
Oh, that's the number one thing I tell patients is weight loss. Now, that's why GLP-1s now have been approved to treat in conjunction to treat sleep apnea. Why? Because of the weight loss. So that's the number one thing somebody can do to get better. So that's one of the things I talk to, I'm more sensitive when I talk to women about that. I've worked with women my entire life, so I'm very sensitive on that. But guys, I can straight up talk to guys about, weight loss is the number one thing you can do. And a lot of guys have never even had hormone levels checked. I tell women too, after a certain age, you better have your hormone levels checked, but definitely weight loss is the number one thing, Terry.
And why is that? The neck thins out?
That's one thing. You do have fat that can accumulate around the neck, the upper chest, also on the borders of the tongue. There's fat in the tongue. The tongue can get smaller. But weight loss in general, is going to improve how many people get off all kinds of different medications. But definitely weight loss is the number one thing somebody can do to improve their sleep apnea.
How does hormone therapy improve sleep apnea?
Well, you mean hormone like testosterone therapy?
No, you just said a second ago about women should have their hormones checked.
Oh, especially if there's going to be a weight issue or some issue where they're going to be gaining weight. Except women come in and like, Doc, I've tried everything.
Okay.
Yes, for women that have had, and I have women come in that have been complaining, like, if somebody's overweight, they know it. I'm not going to ever push these, but I will tell them, the number one thing somebody can do to improve their sleep apnea is lose weight. And so a lot of women are getting tested, if they haven't, it would be like thyroid. I just think it's a proper blood panel after a certain age for all of us. We're all over 50 for all of us. It's definitely a great idea.
It is very difficult to have a patient come in and tell them that they need to lose weight. You have to be very careful with that. But
you have a duty, though. You have a duty to tell them.
And I say it. I do say it. But it's not comfortable for me to say it. But you're right, Mel. We have a duty to say it. Absolutely.
It is what it is, right? And you don't like it. I'm trying to help you.
Yeah,
No,
there's a
you're
certain
right.
way that I would say, a certain way to say it, but you're right, Terry, as dentists, we're not used to telling people to lose weight, but physicians all the time, you got to lose
Yeah.
weight. They'll say, they won't even blink an eye at that.
It's true.
We're just so used to our different, our dental world that we've been in for so long. But now I'm definitely more comfortable talking about it. There's just a certain way that that I approach it with women
Yeah,
in
we're
comparison. The guys,
diplomatic. Yeah.
yes, I'm a little bit more straightforward with the guys.
They're easier.
Yeah.
They're easier, right?
Yeah.
All right.
So I was going to show you guys the rhinometer here real fast, and we're going to, so this back here, this is the specialty equipment. Peg might have to move that.
Yeah, I'm gonna move it up.
Right. Almost.
I know it comes up soon. There it is. There it is.
All right.
Okay. Is that too high?
No, I think that's pretty good.
Okay.
All right. I can move this over a little bit. So the equipment that I use, everything is sound wave based. And make sure. All right. So we already started on Peggy. What I was talking about the nose is this is called the rhinometer. This is the first piece of equipment that I use. Normally, I'm just going to do it here for Peggy, but normally, I have gloves and mask and everything on. But we start with what I'll start with her left side. And this little rubber part goes right around the outside of the nose. And basically, sound waves are going to go up the nose, and we're looking for 3 areas in the nose. So I tell patients, I'm going to go 1, 2, 3, and just going to pause. So here we go. 1, 2, 3, pause. Perfect. I wait for the beep. Now we're going to do the other side.
And what is that check, doctor?
This is called a rhinometer. 1, 2, 3.
Is sound waves?
Oh, let's do right side again. I just found a little something. Get up.
I know I have it.
So just want you to pause. 1, 2, 3. Pause. Perfect. So
When you say pause, you mean don't breathe?
yeah, don't breathe.
Oh, I was breathing.
All right. Well, she doesn't follow
Oh,
instructions.
Peg.
She thinks pause means don't talk.
Yeah.
All right, we're going to go right side and just pause your breathing. Okay, here we go. 1, 2, 3, pause. Perfect. And then let's do left side again.
Okay.
1, 2, 3, pause. Perfect. So what are we looking at here?
All right.
Basically 3 sides of your nose. I'm gonna overlap here. I'm gonna compare your left and your right. So we need this wave. The blue line right here, if you can see, that's the outside of your nose traveling up the nose, 3 centimeters, 6 centimeters. What we look for, these horizontal lines those are 3 specific areas in the nose: the nasal valve, and these are your turbinates. So we want to make sure the wave is always above. So if somebody were to come in and let's say they had a polyp or something in the nasal valve, it would hit and it would just nosedive down. Or if there's a constriction, this could also be deviated septum, but these are the turbinates. If it's below these bottom white lines, patients like this, I would refer to the ENT and I wouldn't recommend mouth tape. So this is the first part of the workup. The next is this piece of equipment is called the pharyngometer. Sorry, that's the rhinometer. Basically, they breathe through this tube, and I can see the outline of their airway, their mouth, and then the upper part of their airway. Then I'm having them do this specialized exhale, and I can see where's the airway collapsing. And then I'll reposition their jaw. I do measurements on how wide they can open, how much their mandible moves on a horizontal axis. And then I test them in different jaw positions to see what's the most favorable. That's where we're going to do the digital scan of the upper and lower teeth, and that I call it a therapeutic bite position. But so Peggy was okay. She's slightly constricted on her right side in the nasal valve. So areas like this, things that help are going to be nasal dilators, which this is one type. Basically, nose vents, generic, $9-10 on Amazon. And basically what they are like these little cones that you can put it goes right in your nose. These go internally and help keep your nose open, that nasal valve, this area. The other thing that helps is the intake, which is that new one that's all over social media, which is like a little magnet that goes on the outside. And it basically, there's 2 little magnets that you put on with these little pads. And then when you put the strip over it, pops your nose out. So people breathe a lot better. I wear mine because when I inhale, this side collapses. So even when I'm doing yoga or I'm at the gym, I'll wear nasal dilators at times. And it really helps for exercise.
Oh, you can wear them working out. Oh, that's cool.
If needed, they'll help patients. Yeah. But for you, you could try it,
Definitely.
So this
Yeah,
is
it doesn't make your nose bigger, does it? It doesn't make your nose bigger, does it?
not permanently, temporary, just temporary. But anyway, but you're okay, Peggy, on everything like this. So
Just a little constriction.
a little slight. So that would be mechanical. And one little test you can do, Terry, for patients called a caudal test. So you have somebody breathe with their lips together, normal, and then what you can do is you pull out right here. I think the Dr. Smith did that.
Oh, I breathe so much better.
And if you breathe better by pulling it out, then
oh my God, so much better.
Then nasal dilators of the intake will work for you.
Oh, so much better.
See, so little things like that.
So much better.
I don't see a difference.
Oh, I do.
I don't have
Okay, cool. How about you, Mel? Does that work? I know, I really can.
I'm not gonna. I'm gonna do it afterwards.
Oh, come on, man. You only live once. Jeez.
I'm gonna do it later. I hope I'll be living in 25 minutes.
Okay. All right. Here we go. Oh, that's cool.
So yeah, any other questions? You guys ask away.
Are there any questions? I don't see the questions, Peg.
What
You see questions?
what about medication?
Medications for apnea or
Sleep apnea.
The only approved medication right now, Mel, is just all the GLP-1s, whether it's Ozempic, Zepatide, just for weight loss. That's the only medication right now that's approved. The only other treatments are going to be, CPAP. If somebody has moderate or severe sleep apnea, that's usually number one line of treatment. If you can't wear a CPAP, then oral appliance therapy, and also Inspire, which is, we talked about, the hypoglossal nerve stimulator that an ear, nose, and throat specialist does. There are certain types, like Terry, like you said, your son had mandibular advancement. It's really aggressive surgery, but that's something you can consult with a properly board certified, oral surgeon for that. And there's different procedures they do for the throat. There's a UPPP where for the right patient with big old tonsils, they can remove the uvula, the tonsils, and any extra tissue. I call it the roto-rooter. It cleans everything up, but there you still get patients that the apnea does come back. That's like a 50-50 cure on that. But there are different surgeries, but medication only for weight loss.
How much is a mouth appliance out of pocket?
This is the thing, and I'm an insurance provider, so I work with Medicare, with all big insurances. I'm even very proud to be a veteran provider, so I work with our VA here locally. It could range, if you use your medical insurance, it could range from zero to, it's rarely would ever go up to $1,000 out of pocket. Like that's out of pocket, but usually it's in the hundreds of dollars for most patients.
So insurance will pay.
Yeah,
for it?
now insurance will pay for it, but you have to be so it's kind of a unique thing. I'm a dentist, but I'm a medical provider for these insurances for Medicare and for VA and Aetna, Blue Cross Blue Shield, all that. So if a dentist tells you it isn't covered, it is, but you have to be able to bill medical insurance. So that usually comes with specialized billing companies. But normal price for most dentists, if you're just doing it, it's going to be for patients anywhere from, I'll give you a range, $2,500 to about $3,500. If you just wanted to come in and just pay for the workup and pay for the appliance.
Can you also discuss how the correlation between sleep apnea and diabetes, how it affects diabetes or vice versa?
Type 2 diabetes. It's going to be when you have that big insulin, that big epinephrine, and you have that big surge from the fight or flight response. Over time, patients become insulin resistant. So there is a direct correlation to that. So I was just reading up, patients have type 2 diabetes. There's about 50 to 70% of them that have underlying obstructive sleep apnea that's never been addressed. So to me, it's like nowadays, since it's so easy with the home sleep testing, to me, I don't know how any doctor that even thinks their patient, could have potential sleep apnea if they're complaining about being tired during the day, if they're complaining about, I never feel rested. My wife says I stop breathing at night. I snore. I want to fall asleep at stoplights. It's so easy to do a home sleep test, and insurance covers it. You can do a few a year, and it's covered. And anybody that's doing hormone replacement therapy, those doctors, neurologists, they should all be cardiologists. My gosh, AFib, direct correlation. So there's so many correlates to so many of their diseases, and it's in conjunction with so many of their diseases, but definitely type 2 diabetes.
It's a
So
foot
what
precision.
happens first? Does the apnea happen, then high blood pressure and cardio issues, or is it cardio then apnea? How does that work? In what order?
Well, if somebody's had chronic untreated obstructive sleep apnea, especially when it comes to, let's say, like AFib, you know, you have decreased oxygen flow coming down. So your heart has to work extra hard. That you can get some dilation of your atrium, and then patients of that. There's also that's one of the things that leads into also to that nighttime urination and stuff like that. It's an ANP, a different peptide that's produced that wants to make you pee more at night. But the correlation is, yeah, your heart has to work harder, Mel, over time to pump out more blood, because think about it, your airway constricts, your brain goes, we don't have enough oxygen. So your heart rate goes up, your blood pressure goes up, and you release cortisol. And that repeated, in combination with the desaturation, your heart has to work more. You have constricted blood vessels, and you're trying to pump out more blood. So your heart's working more. So I would say, I'm not a cardiologist, but I would say that, most, I can't tell you if it started before or after, but you see it a lot with patients that untreated obstructive sleep apnea with AFib patients.
How about if
What
you just give them a little
causes?
bit of a nasal cannula with some oxygen?
Yeah.
Just,
No, good question, because there are patients. So let's say we have patients that we treat with oral appliance therapy that we're not getting the result, because the normal protocol is once you've been wearing the appliance and any other of my recommendations that I give to patients, you're going to be retested with the appliance and anything else you're doing 3 to 4 months later.
okay.
It's just, just to make sure, how we call it an efficacy study, how well somebody's doing. Now, if somebody's O2 is still dropping, they're doing everything. Let's say they're a bit overweight, they're not going to really do much else to improve their health. They can use nighttime oxygen in conjunction with the appliance if they're going to not wear a CPAP at all. They're absolutely, I'm claustrophobic, I can't put that mask on. So yeah, there are some patients that's why we work closely with their pulmonologist or their cardiologist, and they'll prescribe
Just a nasal cannula at night.
Yeah.
How about just a normal person that wants to get more oxygen into your body? Would it help?
I don't see why. I mean, it can't hurt. I mean, but I would say, why not get the pulse oximetry ring and see what's happening to your oxygen at night?
So the oxygen level, why does it go up and down during the night? Like mine will go like 97, 98, and then it'll go like 94, then go back up. Well, what causes the fluctuation?
And those are, honestly, Mel, those are minor fluctuations. Like when you start dropping below 90 or getting to the 80s, 70s, we get patients even in the 60s. So in your case, it's probably a little bit of the narrowing of the airway. That's it. So those are called like hypotneas, and on sleep tests, they'll test a 4% drop off of your baseline. If you're 65 and above, they look at a 4% drop. If you're under 65, it's a 3% drop. And those are called hypotneas. And those are one of the things they check off. So the way that you're diagnosed is called an apnea hypotnea index. So apnea, 10 seconds plus without breathing. You add in, so all the apneas plus all the drops in oxygen, the hypotneas. So sometimes you get patients, like you could be diagnosed and you could have a bunch of hypotneas and you never have apneas. So, but it's usually a little bit of narrowing of the airway. Or it could be the body position, if you sleep on your back at all, your tongue and your mandible could be going back. So it could be that, but it's usually narrowing of the airway.
And that's just, because mine will go 97, 98, and then it'll go like 95, and then go back up. Just small little fluctuations, but
That's normal.
that cause it. That's normal.
Yeah, that you would be the exception of my patients. Most of my patients, one of the things I look at is how long under 90% oxygen did they go at night on their sleep studies.
Oh, I see.
Like if it was you, I'd be like, wow, Mel, you spent, and this wouldn't be an exaggeration, you spent over 2 hours under 90% oxygen. Then I tell patients, like, when you're at the hospital, if you have the pulse ox on, and you go under 90% oxygen, the nurses are coming in to make sure you're okay. So imagine night after night, you're desaturating below into the 80s or 70s night after night. I mean, there's a lot of
my son was so low. His was so low, and so now he's normal. But yeah, he had it bad, and he couldn't figure out why he was restless. He got depressed. He couldn't figure any of it out. So once they did the
and you're hitting on all those topics.
sleep apnea.
How many people could have underlying obstructive sleep apnea? It could affect so much else of their it affects their lives so much, and it's just apnea that's undiagnosed.
Well, I'm his mother, and I never even thought of it
How
because
long
I didn't think that people that young would be getting it, but it's not, anybody can get it.
Yeah.
How low did his dip, Terry?
I think it was like 60 something, 70 something. It was very
Wow.
bad. It was
That's
very low,
low.
very
For a
low.
young
And what
man.
caused it? What caused it?
He had a recessed jaw, so he had double jaw surgery. I wouldn't recommend it. So they cut his jaw, upper and lower, his maxilla, his mandible, and moved his lower jaw forward. So what that does is that pushes your jaw forward, opens up your airway, so he's able to breathe better. Because when your jaw is pushed back, right, doctor?
Oh, sir.
Oops. Let's say that again, Terry. You broke up.
So when your jaw is pushed forward, it opens up your airway. So they took his lower jaw and pushed it forward. But when your jaw is pushed back, and a lot of people, their profile, their chin is recessed back, it blocks your airway.
Oh.
Yeah, so they're anatomically, their airways are going to be smaller and that jaw's back there. So that is one of the treatments. I don't think I've had, honestly, I've been doing this full-time 7 years. I haven't had anybody yet that I've sent for that because I don't see it that often. Most of the time, it seems like orthodontics, when kids are younger, if they have that issue, they're going to do they're going to do that type of surgery in conjunction with orthodontic treatment.
He
But yeah,
wasn't, his orthodontist wasn't done like
yeah.
that. So you're exactly right. Orthodontics can really correct that before it becomes an issue.
Yeah, no, it's funny you mentioned that about the retrognathic mandible. I was watching the World Series, and the World Series was on. There was one of the pitchers on the Dodgers that when you saw him, his jaw was way back.
Oh wow.
He had huge bags under his eyes, and his profile, instead of being a straight profile, he was really bad. And I made a comment. I made a comment about, like, I put up there. I didn't say his name or anything derogatory. I just said how this young man was able to reach the highest level of his sport with that, because obviously the guy's gonna have sleep apnea. He probably wears a CPAP. I don't know, but that's one of the things that was just struck me, like those bags under his eyes, the retrognathic mandible, and he was still like, I just made a comment, like, imagine if this guy had that proper surgery done, had his sleep apnea treated. I mean, he's already amazing. I couldn't even imagine.
That's what Dr. Smith was talking about when you get all that taken care of.
Yeah, no, I loved the Dr. Smith, your podcast last week. I was intrigued watching it the whole time. He's an impressive man. So, you guys are providing a lot of great information for the public out there. It's great.
Instagram Live.
Instagram Live.
No podcast.
Someone outed the guy, Blake Snell.
Say that again.
Blake Snell, they said.
Like Snell.
Yeah, exactly. I didn't want to say any names. I'll tell you what, Mel. I just put a picture of it up. I had more, and I'm not a big in the social media guy, but I had there was my one that went viral, and I never intended it. I was just putting it out for the public, but I got a lot of people that were really upset.
Really?
Like I wasn't making fun of the guy. I was just saying,
pointing something out.
Yeah. Now that you say it, because I know what he looks like, right? He does have a smaller jaw. And I don't remember, that's just the way he looks to me,
Yeah.
But you're looking at it from a doctor's point of view.
That's
But now that you told me, yeah, he does have a smaller jawline as back further.
And that's what Terry was talking about with her son, the type of surgery they did. So that they have oral surgery, it's a very, complicated and long healing. You have to wire your jaw shut, but they actually bring the jaw forward. Sometimes the maxilla.
Could he look like that and not have it?
I would say he probably does. If you have that much of a retrognathic mandible, along with the black, the pouches under your eyes, it's pretty much that's pretty much a guarantee.
You go over and see him. He's over in Glendale right now.
Yeah, no, he's and he's so impressive. The comment that I was making was that how a guy like that could reach the highest possible level of athletics for baseball, for his level to be that amazing of a pitcher and have sleep-related breathing disorders more than likely. It was amazing how the guy can do it. He's that talented.
Wow.
Yeah.
That's really cool. Well, any other questions? Anybody out there have any other questions before we wrap this up?
It was really great. I learned a lot.
Really great. Yeah, definitely.
And there's and I can talk this up. Yeah, and there's a lot. There's doctors in your area that I know that that I'm trying to think of. There's a few I think in Houston that I know that Suzanne Tai is one that's amazing. She has a great clinic. I believe she's in
Dr.
Houston.
Sue Ellen Richardson.
Sue Ellen Richardson,
She's a,
absolutely. Sue Ellen's
she's a
great.
very good, I was going to bring her name up. She's a very good friend of mine. In fact, she gave me a lot of her patients because she quit practicing general dentistry
Yes.
and just does sleep apnea.
I just saw her
Yeah.
last month. She's one of my favorites.
We
I'll
will,
have
you
to
guys.
tell her
Is
you
there
said
is there
hello.
any doctor? Is there any preventative things if someone's out there listening and they're in their 30s? They go, well, I don't want to get it. Is there anything preventative that you can do so you don't get it in the future?
Well, I mean, controlling your weight would be number one, but I would tell anybody that even thinks they do, just get a home sleep test done. It's so easy. There's companies out there that, that can help you get a home sleep test. We help all of our patients. Go to your primary care doctor, but I would just start with a home sleep test and see if you're diagnosed or not. Based on that, that would dictate the type of treatment. And that, and then also, main thing I'd say is healthy lifestyle. Like, we all try to have, I mean, work out on a regular basis, eat healthy, do healthy things, not, it's the weight gain is, like we said, is the number one thing that makes it worse, but it's the number one thing that makes
What
it better.
what percentage do you think of Americans have sleep apnea?
What percentage? Right now, there's probably 85% of Americans, the latest study I read, 85% of Americans undiagnosed. That's about 68 plus million people that are undiagnosed.
Wow.
So it is a major problem that is just not treated. And I think a lot of it is just a lack of awareness, a lack of education, and a lot of times it's people being scared of going in like,
Yeah,
I
lack of
can go,
testing.
yeah, I'm gonna go sleep in one of those labs and have all the stuff glued to me, and there's no way I'm doing that.
But
And thinking that,
the other thing is not just that. People just relate snoring to sleep apnea. They don't relate being tired. They don't relate lethargy. They don't relate any of that. So they don't relate it, and so they're not going to associate it with sleep apnea, and that's a problem. We need to create more awareness, and as dentists, that's what we can do because we see our patients more frequently than any other professional.
yeah, and that as dentists over the years, especially family practitioners, you get so close to the families. That's part of the nice thing. You're seeing them on a regular basis. Being a family dentist, general dentist, I was here regular. I would see Peggy, minimum twice a year, if not more, because she'd bring Dakota in. So you get these relationships. These patients. They have trust in you. So dentists can you can get patients sleep tested, but a lot of it, you're absolutely right. It's awareness. It's primary care doctors being aware, different specialists being aware, and get people tested. And patients know that it's easy to get tested. And treatment, there's all kinds and it isn't just CPAP. A lot of people think the only treatment is just CPAP. Once patients are aware that, oral appliance therapy is another form of treatment, there are different things, but it's just getting tested and creating an awareness.
How about I
Doc,
have
what made you switch from being a regular dentist to being a specialist?
You want the truth, Val? No, honestly, I was I was really burned out on general dentistry. I've been a dentist since 93. I moved to Vegas in 94. I practiced for 25, 27 years, and I was getting really burned out. And it wasn't until I went to I entered this world by an absolute fluke. I didn't have enough CE one year, and I was running around for any CE that I can get to renew my license, and I ended up taking a course in Southern California at this big lab, and it was on sleep apnea, and I was like, this is interesting, but I still needed more credits. So I asked the guy, which actually this company behind me that was doing the seminar, uh, and I asked the guy that was running the seminar, hey, do you know any other CE that I can go to? And he goes, well, there's a national meeting in Denver, American Academy of Dental Sleep Medicine. So I went to that meeting and I met a few doctors. And once I did more meetings after that, it kind of really sparked my attention. I started doing it in my office, kind of dabbling in it. And it wasn't until I met like a Dr. Kent Smith, he's from Texas, and another female dentist from San Diego that they said, this is all we do. And I go, you don't drill and fill and give shots or any of this stuff, take out teeth. No, we just do sleep apnea. And once I found that, that's when I went full force, like, I got to learn more about this. And I got my diplomat in this through one of the organizations. So, and just more education, more training. But it was a total fluke how I got into it.
Okay, but now you're schooled in both of them.
Yeah, no, it was a whole learning curve to have to learn it because you learn a lot of medicine. You have to learn ENT stuff. You have to learn hormone things. It's just a lot more education. But once you love it and you're on that path, it'd be like getting certain type of law that maybe somebody's intrigued in. And once you get into that specific type of law, you educate yourself on it and you dedicate it and you just do one thing, you become great at it.
There's another
Understood.
question. What about TMJ and the asymmetrical face?
Ooh, well,
Yeah.
getting into Team J, that's a whole
Other-
other lecture. But we do see there is a correlation. There are patients that have temporomandibular disorders, TMD or TMJ is the joint, that will come in and clicking, popping, different things like that, limited opening. So we do see that with patients. That's another type of treatment. But ironically, the oral appliance therapy that you wear at nighttime for sleep apnea keeps your mandible in a slightly forward and open position and keeps the condyle, the top of the bone, on the disc. So it really is a nighttime orthotic for patients that have TMD. And for patients that are really bad, they would have an oral orthotic they wear during the day to keep that condyle, to keep it on the actual disc. So, and there's even PRF injections, different biologics. There's different, more advanced treatment for TMD, but the asymmetrical face, I would say, is more the retrognathic mandible that we talked about. But if anybody that thinks they have potentially HEPAP, just get tested. It's way too easy.
Right.
Like I said, we're going to get Peggy tested. We already got her set up with her WatchPAT. And by the way, here is your WatchPAT.
Oh,
This is yours, ready to go.
thank you very
And
much.
I got to throw out, there's a company called Lux Medical that I work with, and Nusha, the owner, and her husband, that's a sleep physician. It's owned by a local sleep physician. And all the data, everything is Dr. Jack Collier, local sleep specialist pulmonologist, does all the interpretations for all my studies. So Peggy's going to be getting her WatchPAT. And this is how easy it is, like we talked about. A watch, one finger probe, and one lead that goes to the top of your chest. You sleep with this at night, and all the data, there's an app, the WatchPAT 1 app, all the data goes to the sleep physician. He interprets the data, and then he makes the diagnosis.
Fantastic. And we'll have you back on.
And we're gonna get you guys with your oral appliances too, and then you give us feedback on the oral appliances.
Mel will be out here in what, 2.5 weeks. So
Yeah, Mel, come on in, and we're gonna scan you here at the office.
Okay, great. I'd love to do that. Thank
Oh,
you.
Terry, you're gonna
Thank
be here
you
as
so
well.
much.
Terry's
Huh?
gonna be there
Yeah,
as
I'll
well.
be there too.
Yeah, you
We have
guys
the whole
can get
crew
sick.
in.
All right.
Party.
We'll have a sleep apnea party here at the office.
We'll be up all night.
That was a good one, Mel.
Yeah, good way to finish, Val.
All right, Joe, thank you very much.
All right. My pleasure.
That was a good one.
All right, you guys.
It's nice to meet both of you guys.
Thank you, guys. Thank you.
Thanks.
Thanks
Good
for your
night,
time,
guys.
doctor.
I'm going to give you a good night's sleep. Huh?
That's
There
right.
you go.
Get your snore lab going too, Terry. See.
Definitely, right? And I'm going to post all this information in the comments so you guys have all his information. Everything that we talked about tonight will be in the comments. And thank you again.
My pleasure. I loved it. Thank you, guys.
Bye,
Thank
you
you.
guys.
Bye.
Have a
Good
good
night.
night.
Bye.